This is Randall Schell, and I'm producing a podcast entitled Anesthesia Pharmacology Keyword Review 2016. This is part one of three-part series on anesthesia pharmacology. We will first look at keywords and some gaps in knowledge. Gaps in knowledge are where CA3 residents in the United States missed a question, more than 50% of them. And we will first look at local anesthetics and neuromuscular blocking agents in part one, opioids, IV induction agents, and inhaled anesthetics in part two, finish inhaled anesthetics, talk about some pharmacokinetic principles, and then some miscellaneous pharmacology topics in part three. First, look at some keywords from 2015. First, neuromuscular junction, anticholinesterase function. You know that anticholinesterases inhibit acetylcholinesterase and raise acetylcholine levels at the postjunctional membrane. The B in this keyword topic list refers to basic exam. The A refers to the advanced exam. Next keyword was obesity and succinylcholine dosing. Obese patients have increased butyrylcholinesterase or pseudocholinesterase activity and can have a relative resistance to succinylcholine. Calcium channel blocker and neuromuscular blockade. Calcium channel blockers have a pharmacodynamic effect of potentiating neuromuscular blockade. End-stage renal disease and anticholinesterase dosing. We use usual neostigmine doses and glycopyrrolate doses in patients with end-stage renal disease, and don't worry much about the potential issue of recarization because the neostigmine is prolonged as well as the non-depolarizer. Acetazolamide lab findings. Acetazolamide diamox is an inhibitor of carbonic anhydrase and causes bicarbonate loss in the urine and a metabolic acidosis. Anesthesia for electroconvulsive therapy will be discussed in the neural podcasts, but lidocaine, propofol, and other anesthetics tend to reduce the length of seizure during the ECT. Antibiotic cross-reactivity, penicillins and cephalosporins. When you're allergic to one, you potentially can be allergic to the other. However, new evidence suggests that unless you have anaphylaxis to penicillin, cephalosporins can be administered in a penicillin allergic patient who's just had a rash, for example. Benzodiazepine respiratory depression. If you combine benzodiazepines with opioids, there's a synergistic effect on respiratory depression. Butyrylcholinesterase is another name for pseudocholinesterase or plasmacholinesterase, and the substrates that it works on is succinylcholine and ester local anesthetics. Used to be mivacurium included in this list, but mivacurium is no longer available. Etomidate and adrenal insufficiency. Etomidate inhibits 11-beta hydroxylase, cortisol, and mineralocorticoid production, but in most cases this is not a clinical significance. Glycopyrrolate side effects. Glycopyrrolate is a quaternary amine and does not cross the blood-brain barrier, so it's not going to cause CNS effects, but it can cause tachycardia, reduced sweating, and decreased lower esophageal sphincter tone. The mechanism of action of low molecular weight heparin, like other heparins, it acts via antithrombin 3. Transient neurologic symptoms and local anesthetics after subarachnoid block, especially when lidocaine has been used. Patients can develop pain in their back, buttocks, and thighs, lumbar and sacral region within 24 hours, resolving within 7 days, and that's called transient neurologic symptoms. Lorazepam metabolism. Lorazepam undergoes phase 2 metabolism, which is glucuronidation, as opposed to midazolam, which undergoes phase 1 metabolism, which involves the CYPD system. So drugs that affect the CYPD system can affect midazolam's metabolism without affecting lorazepam's metabolism. Metoclopramide is a dopamine blocking drug used to increase lower esophageal sphincter tone, decrease pyloric tone, increase gastric emptying. And Meyer-Overton correlation refers to the correlation between lipid solubility and potency. There was other keywords in 2015, relaxant and drug interactions. There's many of those. We'll go over some of those. Nitrous oxide, how it fills closed air spaces, including sulfur hexafluoride gas bubbles that can be put in the back of the eye during retina surgery. Opioid metabolism and opioid prodrugs intolerance will be discussed, but opioid prodrugs refers to the fact that many opioids, including codeine, require conversion to an active form, in the case of codeine to morphine, before they result in analgesia. Organophosphate poisoning is what occurs when exposure to organophosphate, such as insecticide, results in increased muscarinic activity because of increased acetylcholine. The patient's bronchoconstrict and bradycardic. Tramadol has both mu as well as it increases serotonin and norepinephrine. Mu effects are like opioids, and tramadol is a prodrug requiring conversion to its active form also. Blood gas coefficients, we'll talk about inhaled anesthetic uptake and distribution. Botulism toxin inhibits acetylcholine presynaptic release, while tetanus toxin also inhibits presynaptically, but it does so with inhibitory neurons. So if you inhibit inhibitory neurons, you get excitation, and with tetanus, you get tetanospasms. Mechanism of action of P450, those cytochrome enzymes are involved in many drug metabolism. In fact, 25% of drugs are metabolized by the P450 system. Opioids in renal failure. We'll talk about morphine and morphine 6-glucuronide, Demerol and meperidine, and we'll talk about Dilaudid and its glucuronide metabolite also. Ketamine, the mechanism of analgesia is NMDA receptor, and anaphylaxis treatment should be epinephrine early. Some gaps in knowledge from 2015. More than 50% of the CA3 residents did not know that an increase in butyrylcholinesterase activity in morbidly obese patients contributes to their relative resistance to succinylcholine. Therefore, oftentimes, succinylcholine will be administered at about 1.5 milligrams per kilogram ideal body weight in morbidly obese patients, and that the 3-glucuronide metabolite of hydromorphone or Dilaudid will accumulate in renal insufficiency and can cause neural excitation and cognitive impairment. And as we pointed out in the keyword earlier, lorazepam undergoes glucuronidation in the liver as opposed to midazolam, which undergoes phase 1 mixed oxidase metabolism. There are many other years keywords shown here, and I'm just going to leave them up for a moment on the screen, including some gaps in knowledge. If you desire to look at those in detail, please stop the slides and look them over. And we'll go back all the way until approximately 2008, which is here, actually 2007. And then we'll start with our review now with local anesthetic pharmacology. Local anesthetic potency is related to lipid solubility. That is, the more lipid soluble local anesthetic, the more potent it is. Therefore, tetracaine and bupivacaine are more lipid soluble than lidocaine and are more potent. Onset of local anesthetic state correlates with the pKa. In fact, the closer the pKa is to physiologic pH of 7.4 for a given tissue pH, for example, the faster the onset. But if we look at the pKa's of most local anesthetics, they range from approximately 7.6 up to almost 9. So those with the lower pKa's that are closer to a pH of 7.4 have a faster onset. Remember that when the pH is equal to the pKa, half exists in the ionized form and half exists in the unionized form. Now, chloroprocaine has a fast onset, but its pKa is all the way up at 8.7. Well, why is that? Because we use high concentrations with large amounts of molecules of chloroprocaine, i.e. 2 to 3%, rather than, for example, bupivacaine, 0.25% or so. Alkalinization, adding bicarb to a local anesthetic, can speed its onset because it increases the percentage of the B form, which is the unionized form, which is the form that crosses lipid membranes. When it crosses lipid membranes, it then becomes ionized when a hydrogen ion binds to it, and then it binds to the inside portion of the sodium channel, blocking it. Acidosis, where there's lots of hydrogen ions around, results in the BH plus form of the local anesthetic, which doesn't cross lipid membranes well, and you have resistance to local anesthetic effect. Local anesthetics are racemic mixtures in general. An exception is lidocaine, which is achiral. Ropivacaine also is not a racemic mix. It's supplied as just the S form in an attempt to get rid of the R isomer, which has more potency for neural and especially cardiac sodium channels. So ropivacaine was developed in an attempt to reduce cardiac toxicity. Allergies to local anesthetics are rare, whether antigen-antibody reaction like a type 1 reaction or a cell-mediated immunity type 4 reaction. Both are rare, and both ester and amide reactions are rare. However, esters are more common than amide. Esters are metabolized to pyraminobenzoic acid, which patients are allergic to. The preservatives methylparaben and metabisulfite can be added to some local anesthetics, and that may be what patients are allergic to rather than the actual chemical structure of the ester or amide. Skin testing with preservative-free local anesthetics is rarely used in working up a patient with potential allergies to local anesthetics. So allergies to esters, because of their conversion to pyraminobenzoic acid, are more common than amides. Systemic toxicity, however, is more common with amides because esters are rapidly broken down in the blood, while amides are chewed up slower by the liver. The site of injection also determines the instance of systemic toxicity. For example, if you inject intravenously, obviously you can get very high plasma levels. But tracheal local anesthetic applications such as benzocaine spray in the airway or lidocaine prior to an awake fiber optic intubation, for example, can result in very high local anesthetic levels in the blood. And the classic is intercostal nerve block, which results in very high local anesthetic levels. And then you can see that caudal has higher levels than thoracic or lumbar epidural, than brachial plexus, than sciatic, than simple subcutaneous injection. One of the first signs of local anesthetic toxicity is CNS tinnitus and circumoral numbness. Cardiovascular effects are later if high doses are given, and toxicity again presents initially with the circumoral numbness and the tinnitus, excitation and seizures, followed by coma, respiratory arrest, and if in high enough doses, the blockade of sodium channels in the heart can result in AV block and decreased contractility of the heart, vasodilation, and hypotension. Remember that not only does lidocaine act at cardiovascular sodium channels, but dilantin acts at sodium channels also. Now, the R isomer is more toxic, therefore ropivacaine in its S form is less cardiotoxic. If a patient is given large volumes of bupivacaine that go intravascularly and cause local anesthetic systemic toxicity, we often will hyperventilate the patient first, although there is some controversy about this. And hyperventilation and airway management, the reason why hyperventilation is done is to reduce cerebral blood flow and delivery of the local anesthetic to the brain. Prolonged resuscitation may be required because bupivacaine is a slow in, slow out sodium channel blocker. We tend to use lower doses of epinephrine and avoid vasopressin because some dog studies have suggested that pulmonary hemorrhage can occur with vasopressin, among other things. We can give lipid, for example, in an adult patient, 100 mils of 20% lipid solution. This is not propofol, but the lipid solution can bind bupivacaine and help us reduce the plasma levels. And if a patient develops resistant ventricular fibrillation, where drug treatment is required, amiodarone can be used. We tend to avoid calcium channel blockers and beta blockers for dysrhythmias. They already have reduced cardiac contractility because of the toxicity. So ABCs first, and if they're seizing, suppress the seizures, for example with benzodiazepines like midazolam. Toxicity tends to be potentiated by hypoxia, acidosis, and hypercarbia. And if a patient's pregnant, there's an increased risk of toxicity. Cocaine toxicity is the next topic, and the maximal dose of cocaine is 3 milligrams per kilogram when it's applied topically. This can be used during ENT surgery, for example, to provide mucosal analgesia and also to vasoconstrict, reducing blood loss. Cocaine blocks the reuptake of norepinephrine. If there's more norepinephrine around, it can have its alpha vasoconstricting effect on blood vessels, and that's what cocaine does. Vasoconstricts, resulting in hypertension. The increased catecholamines can result in ventricular ectopy and tachycardia, and the norepinephrine increase can actually result in myocardial ischemia and coronary vasospasm, which, if it occurs with cocaine toxicity, should be treated with nitroglycerin first. Do not use beta blockers first, but nitroglycerin. And then if the patient continues to be tachycardic, beta blockers can be added after nitroglycerin. The very young and the very old are especially at risk for local anesthetic toxicity, mainly because of decreased clearance and increased absorption, resulting in increased systemic levels. Now, sometimes we add epinephrine to our local anesthetics. Epinephrine tends to decrease the absorption of the local anesthetic by vasoconstricting. It can prolong lidocaine's effect more than the other long-acting local anesthetics, such as bupivacaine. So it's not so common to add epi to bupivacaine, but epi may be added to lidocaine to prolong its effect. Epinephrine can also be put in peds caudals as an indicator of systemic toxicity. For example, if a local anesthetic with epinephrine is injected caudally in a child and high levels go intravascular, increased heart rate can occur from the epinephrine, but also peak T waves. And so you should be monitoring the electrocardiogram for T waves and heart rate during injection of caudal local anesthetic. Methemoglobinemia is the next topic, and methemoglobin refers to when hemoglobin is oxidized from the Fe+2 to the Fe+3 state, and the hemoglobin then cannot bind oxygen. Prilocaine is a local anesthetic that is present in Emla and used to be used in nerve blocks. Benzocaine is a topical local anesthetic applied mucosally, for example, for fiber optic intubation. And if you happen to be doing a awake fiber optic intubation, for example, spraying benzocaine in an airway and the patient's saturation started to drop, but they actually looked okay, they weren't tachypnic, saturation starts to drop towards 85%, you happen to draw a blood gas and note that oxyhemoglobin is decreased and methemoglobin is increased, that's methemoglobinemia. And methemoglobin absorbs at saturation at 85%. Therefore, if the patient's normal saturation is 98 to 99, it will decrease towards 85. If they happen to have a very low saturation as their baseline saturation, it may rise towards 85. That might be the case in a child with congenital heart disease and shunt, for example. The treatment for methemoglobinemia is rarely needed other than just stop giving the local anesthetic and apply oxygen to the patient, occasionally hyperbaric oxygen. And one of the specific treatments is methylene blue, 1 to 2 milligrams per kilogram of a 1% solution over about 5 minutes. That is given to reduce Fe+3 back to the Fe+2 state. However, a contraindication to methylene blue is a G6PD, or glucose 6-phosphate dehydrogenase deficiency, because methylene blue can cause hemolytic anemia in the patient. In this case, with someone with G6PD, you may need to transfuse the patient to give them normal hemoglobin and possibly dialyze the patient. Emla Creme contains lidocaine and prilocaine can cause methemoglobinemia. When you apply Emla Creme to a patient's skin, it can result in skin blanching. It'll often turn white. There are contraindications to where you should put Emla Creme. It should be on intact skin, intact such that it's not used for incisions, for example, or broken skin or mucous membranes. Also, you shouldn't put it on infants less than 1 month old, and shouldn't use it in patients with a predisposition to methemoglobinemia, like someone with G6PD, because it is prilocaine or contains prilocaine. Transient neurologic symptoms is the next key word. TNS refers to the situation when a patient has had a subarachnoid block, usually with lidocaine, and they develop within 24 hours lumbar sacral nerve root pain. And that is low back pain, buttock pain, and posterior thigh pain without any sensory or motor deficits. Very important. No sensory or motor deficits. Lumbar sacral nerve distribution within 24 hours and completely recover within 7 days. It's not just hyperbaric lidocaine that causes this, but other forms of, or not just concentrated lidocaine, but also other forms of lidocaine can cause it. And that's the most common local anesthetic to cause TNS. Tetracaine and bupivacaine have also been associated with, but not in the same incidence. Incidence tends to be highest with lidocaine in outpatients, obese patients, in the lithotomy position. And if you make this diagnosis, there's no sensory or motor deficits, you can give non-steroidal anti-inflammatories, and it's expected to resolve within 7 days. Liposuction and lidocaine toxicity is the next topic. When tumescent liposuction is performed, large volume of fluids with a very dilute local anesthetic, for example, lidocaine 0.025 to 0.1%, very dilute lidocaine, and epinephrine 1 to a million, which is only 1 mic per mil of epinephrine, as compared to the usual epinephrine of about 1 to 200,000, which is 5 mics per mil. So very dilute lidocaine, very dilute epinephrine, in high doses of lidocaine up to 35 to 55 milligrams per kilogram, as compared to the usual subcutaneous infiltration doses of lidocaine of approximately 3 to 7 milligrams per kilogram, whether epinephrine is included or not. So this is large doses of lidocaine. Why don't we have lidocaine toxicity all the time? Because there's low blood flow to adipose tissue. The epinephrine in the solution vasoconstricts and reduces absorption, and there's some sequestration of the lidocaine in the fat that the fat is then removed with the liposuction. Peak lidocaine levels, however, occur about 12 to 14 hours after injection, so a patient may even go home and then have symptoms of local anesthetic toxicity like circumoral numbness and tinnitus, for example. You should not do large volume total aspirant liposuction in an office-based setting because of the potential complications such as greater than 5 liter total aspirate. You can have lots of blood loss, you can get into lidocaine toxicity issues, and even fat embolism. Mortality can occur secondary pulmonary embolism, fat embolism during the time of removal of the fat. Some can get into the blood, and sudden drop in end-tidal CO2 could be indicative of fat or pulmonary embolism. Blood loss can occur, and toxicity from the local anesthetic usually presents later. Placental transfer of local anesthetics. Local anesthetics are weak bases that can exist in the B and the BH plus form, the unionized and the ionized forms. They are also bound to proteins like alpha-1 acid glycoprotein. Placental transfer can occur of the local anesthetic when it's injected into the mother, and that local anesthetic can cross over into the fetal side in the B form. And then if the fetus is having problems, i.e. fetal acidosis, there's lots of hydrogen ion around, the B form can be protonated to the BH plus form, which then is ionized and doesn't cross lipid membranes well, and that's called ion trapping. And you can have higher concentrations of the local anesthetic in the fetus rather than in the mother. Bupivacaine is highly protein bound, and remember, it's the free drug that passes over, so lower fetal blood levels of bupivacaine, because it's highly protein bound, occur than does lidocaine. And chloroprocaine tends to be the least placental transfer because it's rapidly metabolized by esters in the mother, and it tends to be the safest local anesthetic when fetal distress is present. Here's a question for you. Which of the following statements concerning the cardiovascular effects of bupivacaine and bupivacaine toxicity is true? A, does bupivacaine quickly dissociate from cardiac sodium channels during diastole? No, it's a slow in, slow out sodium channel blocker. Is cardiovascular toxicity decreased during pregnancy? No, it's increased. Diltiazem should be used to treat associated supraventricular tachycardia if it occurs. No, diltiazem is relatively contraindicated, and systemic vascular resistance is decreased, and that is true. There is sodium channel blockade in the heart with AV block. There's hypotension and reduced cardiac contractility. Let's switch gears now and talk about neuromuscular blocking agents, starting with succinylcholine first. Succinylcholine binds the postjunctional nicotinic cholinergic receptor, which is a 5-unit receptor, and 2 of those units are called alpha subunits. It's those 2 alpha subunits that are important for binding both succinylcholine and the non-depolarizer rocuronium, as also the other non-depolarizers like pancuronium and vecuronium. Succinylcholine actually increases lower esophageal sphincter tone. We used to think that and worry somewhat about the fasciculations that are caused by succinylcholine and the fact that maybe intra-abdominal pressure might go up when succinylcholine is administered with increased intra-abdominal pressure, possible increased regurgitation, but actually increases lower esophageal sphincter tone. Interestingly, when you hold cricoid pressure, it actually decreases lower esophageal sphincter tone. Dibucaine is a amide local anesthetic that inhibits butyrylcholinesterase or pseudocholinesterase. And pseudocholinesterase is the enzyme in the plasma that breaks down succinylcholine. Now, the normal dibucaine number is considered 80%, and that means if you mix dibucaine with the plasma of a normal patient, that they will have 80% inhibition of butyrylcholinesterase by the dibucaine. A patient that only has 20% inhibition is homozygous atypical, and if succinylcholine is administered to that patient, they can have very prolonged effect from succinylcholine, duration 1 to 3 hours. Oftentimes you have to wait on a ventilator, sedating a patient, for the succinylcholine to diffuse away from the postjunctional membrane and eventually be gone from the patient. FFP sometimes can be given to supply normal pseudocholinesterase, and pseudocholinesterase itself can be administered IV if necessary. So a dibucaine number of 20 says that's a real problem with this patient's butyrylcholinesterase, and there will be decreased metabolism of succinylcholine and ester local anesthetics, but not remifentanil. Remember, remifentanil is broken down by non-specific esterases, and abnormalities and pseudocholinesterase will not affect its metabolism. There can be problems with the quality of the pseudocholinesterase, which is a dibucaine number issue, and there can be a problem with the quantity, which would be an example where the liver is so bad that it cannot produce the protein itself. In obesity, there is increased activity of this enzyme pseudocholinesterase, and the obese patient will exhibit resistance to succinylcholine. And so the ideal body weight times 1.5 is off, or 1.5 milligrams per kilogram times ideal body weight is often used dosing of succinylcholine in an obese patient. Phase 2 block. Phase 1 block is the pattern of twitch monitoring that we see when succinylcholine is used. When succinylcholine is administered in high doses, cumulative doses, or in normal doses when a patient with pseudocholinesterase deficiency, it can begin to look like a non-depolarizing block, and that's called a phase 2 block. When you have a phase 2 block, it starts to look on twitch monitoring like that rocuronium block. A decreased single twitch, fade, decreased train of 4, post-tetanic facilitation, and is actually can be antagonized with neostigmine. That's a phase 2 block. Contraindications for succinylcholine include upper and lower motor neuron diseases, muscular dystrophy, malignant hyperthermia history, burns, and neurologic diseases that are progressive like Guillain-Barré. It is not contraindicated in patients with renal failure, liver failure, or cerebral palsy. In the case of renal failure, that's assuming that their potassium is not elevated. Cerebral palsy is a static neurologic disease, and in liver disease, you may actually have to use an increased dose if the volume of distribution is increased. Open eye injuries, there's a worry about succinylcholine increased intraocular pressure. It does so slightly and temporarily, but bucking on an endotracheal tube increases intraocular pressure much more than that. Increased ICP can occur with succinylcholine, but if a rapid sequence induction is needed and adequate doses of induction agents are used, there's very little effect on ICP and hypoxia, hypercarbia, and again, bucking on an endotracheal tube can result in much greater increases in intracranial pressure than the succinylcholine. Now, extrajunctional receptors outside the postjunctional membrane, proliferate in the case of lower and upper motor neuron diseases, muscle diseases, and burns. These extrajunctional receptors have 5 subunits, with one of those subunits being different, and when they are activated, they stay open longer and potassium moves outside. There's so many of these extrajunctional receptors, and there's a release of potassium such that hyperkalemic arrest can occur. If hyperkalemic arrest occurs, we treat it with calcium to stabilize the cardiac membranes, alkalinization to lower plasma potassium levels. Remember, alkalosis is associated with low potassium and low calcium. Hyperventilate the patient, administer insulin and glucose to drive the potassium into the cell. Beta agonist inhalation can be used to drive potassium into the cell. Sux-induced hyperkalemia can occur from receptor upregulation, like burns is one example. And in a patient with muscular dystrophy, if you give succinylcholine to it, it can result in rhabdomyolysis. And as those muscles are breaking down and releasing potassium, that muscular dystrophy patient who's given succinylcholine, it can be even more difficult than that patient who had a burn given succinylcholine to resuscitate because of continued efflux of potassium. Talking about renal failure and liver disease and neuromuscular blocking agents next. With renal failure, pancuronium, starts with a P, excreted in the P, is prolonged the longest. Vecuronium and rocuronium have both some renal excretion, but mostly hepatic biliary. Cisatracurium, it has spontaneous degradation and is independent of kidney or liver function, and therefore is one of the preferred muscle relaxants in patients with renal failure. Succinylcholine, assuming that you have a normal plasma cholinesterase level, is unaffected by renal failure. However, recent hemodialysis can reduce pseudocholinesterase levels in some patients. Succinylcholine is not contraindicated in renal failure, assuming that the potassium is not high. Liver disease or cirrhosis, Sux is not contraindicated in these patients. In fact, you may need to increase the dose because of the high volume of distribution. Plasma cholinesterase, however, the protein pseudocholinesterase, butyrylcholinesterase, all the same, may not be produced, that is, by the liver in the normal concentration. So if the quantity is reduced, you might give succinylcholine to a patient and then have a prolongation of effect. Increased volume of distribution of neuromuscular blocking agents is frequent in patients with cirrhosis. Large water space for these large ionized molecules to go into. And so you may need a larger initial dose, but then if the liver is not functioning, the dose that you gave may have a prolonged effect. The next topic is neuromuscular blockers in disease states. We'll look at Eaton-Lambert, which is a prejunctional problem, myasthenia gravis, which is a postjunctional problem, and myotonic dystrophy, which is a muscle problem. In the case of Eaton-Lambert, or myasthenic syndrome, often associated with lung cancer, there is decreased presynaptic release of acetylcholine, and the patients tend to be sensitive to both succinylcholine and non-depolarizers like rocuronium. Myasthenia gravis is associated with antibodies to the postjunctional receptors, and there's reduced number of postjunctional receptors. These patients tend to be resistant to succinylcholine. It's okay to administer Sux to a myasthenic patient, but they don't have postjunctional receptors in the usual numbers. And remember that Sux needs to bind to these postjunctional receptors, open them up, and cause a depolarizing block, and they tend to be resistant. However, since there's very few postjunctional receptors, if you administer rocuronium, they are very sensitive, and blockade occurs very easily with rocuronium. Myotonic dystrophy is a muscle contraction problem. Muscles can not relax like they're supposed to. And imagine if you administered succinylcholine to one of these patients and you could precipitate myotonic contractures throughout their body, making even ventilation difficult. Response to non-depolarizers is considered normal, but do not expect them to consistently prevent or relieve a patient who's having myotonic contractures, because this is not a neuromuscular junction problem. This is a muscle problem itself. Periodic paralysis, another disease that a patient can exhibit intermittent skeletal muscle weakness that tends to spare respiration. It can be of the low potassium hypokalemic periodic paralysis form or the high potassium hyperkalemic periodic paralysis form. The low potassium form tends to be more common than the hyperkalemic form. This is not a neuromuscular junction problem, for example, like myasthenia. This is a muscle membrane excitability problem, most likely related to the sodium channel, although there are some papers suggesting that there's problems with calcium and potassium channels. We normally associate periodic paralysis with a sodium channel problem. In the case of hypokalemic periodic paralysis, low potassium causes the intermittent paralysis, so we want to avoid anything that drops the potassium. Stress, where catecholamine levels go up, can cause a drop in potassium. Why? If catecholamines go up, beta agonism drives potassium into cells. Remember, inhaled beta agonists are one of the treatments for hyperkalemia. Carbohydrate loads, glucose solutions. If you give a bunch of sugar to a patient, that along with insulin, the patient's insulin goes up and drives the potassium into the cell, causing hypokalemia. Beta agonist, as mentioned before. In the hypokalemic periodic paralysis form, both SUCs and non-depolarizers are okay to administer. In case of the hyperkalemic periodic paralysis, we want to avoid anything that raises potassium levels. Exercise raises potassium levels. Potassium infusions obviously raise potassium levels. And changes in blood pH, specifically metabolic acidosis. Acidosis raises potassium levels. Alkalosis lowers it. Notice that both cold, hypothermia, perioperative hypothermia could trigger both the hypokalemic and the hyperkalemic form. In the case of the hyperkalemic form, you're going to avoid succinylcholine because succinylcholine raises potassium, and it's the elevation in potassium that results in the periodic paralysis. We talked about pseudocholinesterase deficiency before. The other name for pseudocholinesterase, again, can be butyrylcholinesterase or plasma cholinesterase or false cholinesterase. The normal dibucane number is 80, and if you have pseudocholinesterase deficiency, either quality or quantity, you can have prolongation of succinylcholine and ester local anesthetics. Please note that remifentanil and esmolol are not dependent on pseudocholinesterase for their termination of action. Remifentanil has nonspecific esterases that break it down, and esmolol has RBC esterases that break it down. There are some patients that are on certain drugs like ecothiolate, which is an eye drop used to treat glaucoma. Ecothiolate inactivates pseudocholinesterase, and in patients taking ecothiolate eye drops, if you administer succinylcholine to them, they can have a very prolonged recovery from the succinylcholine. You may have to ventilate, wait for recovery, or supply plasma cholinesterase, either FFP or recombinant. Burns, the hyperkalemic response to succinylcholine can occur within about 48 hours up to years afterwards. So a burn patient who comes in acutely, if you needed to use succinylcholine, you could, but after a short period of time, as those extrajunctional receptors develop, you run the risk of hyperkalemic arrest with SUCs. Proliferation of these extrajunctional receptors occurs with burns, and if you have a large burn, greater than approximately 30%, there's so many of these extrajunctional receptors that I like to think of when you administer ROC. For example, the ROC uronium not only is going to the postjunctional receptors, but out to all of these extrajunctional receptors, diluting the ROC uranium's effect, and you get a relative resistance to non-depolarizers. The next question is a 2-year-old boy administered succinylcholine who develops the following electrocardiographic changes. The most appropriate therapy is which of the following? Could it be esmolol, phenylephrine, calcium, amiodarone, and in this case you can see a peaked T wave. And with a peaked T wave, it would suggest that this is hyperkalemia, and the treatment would be calcium in this case. What about the cardiovascular effects of neuromuscular blocking agents? Well, they can change the heart rate, increase the heart rate, and decrease the heart rate. Pancuronium is classically associated with an increase in heart rate because of its vagolytic effect, while succinylcholine in neonates and infants, they are very highly parasympathetic, and when you administer succinylcholine, they can have a bradycardic muscarinic effect, as opposed to adults, which tend to have sympathetic predominance, and when you administer succinylcholine, often will get tachycardia, unless it's a second dose. For example, if you had a difficult intubation, administered sux, had trouble intubating, mass ventilated the patient started to recover from the succinylcholine, and you administered a second dose, you may see the bradycardia. Now, histamine release also can occur with neuromuscular blocking agents. Histamine is a vasodilator, and succinylcholine is classic for releasing histamine, and atracurium in 2 to 3 times the ED95. ED95 being the effective dose 95 that decreases a single twitch height, 95%. And normally our intubating dose is 2 times an ED95 by definition. And if you get up to that dose with atracurium, you can get histamine release. It's part of the reason why cystatracurium was developed, because it does not have histamine release. So succinylcholine, atracurium can have histamine release. Let's look at reversal now, neostigmine. Neostigmine peaks its effect in about 7 to 10 minutes, and its duration of antagonism is approximately an hour. It's excreted about half in the kidney and half liver. And this worry of recurrization in patients with renal failure is unlikely to occur. Why? Because neostigmine's effect is also prolonged by renal failure. So we tend to use the same dose of glyco and neostigmine even in patients with renal failure. Neostigmine inhibits acetylcholinesterase, that enzyme that is present in the postjunctional membranes or clefts, and when it inhibits acetylcholinesterase, it raises acetylcholine levels. But neostigmine also inhibits pseudocholinesterase, that plasmacholinesterase that's floating around. And if it inhibits that, it can potentiate succinylcholine effect. So for an example, if at the end of an operation you reversed a patient who had been given rocuronium during the operation for neuromuscular blockade, and then you gave them neostigmine and glycopyrrolate, extubated them, but they developed laryngospasm, which you could not break with positive pressure ventilation, and you needed to administer sux. Now you have neostigmine floating around in that patient. When you give sux, the neostigmine actually can block pseudocholinesterase activity, and succinylcholine's effect can be prolonged. Now, what's the rationale for the maximal dose of neostigmine? In adult patients, we tend to limit our doses to approximately 5 milligrams total. And if we give us excessive amounts of neostigmine, you can get a depolarizing-like block. And in fact, in an overdose, depolarization of the end plate caused by excess acetylcholine can result in weakness. And so we tend to limit our neostigmine dose because of the maximal ceiling effect. And if we go past that effect, we can actually have a negative effect and result in muscle weakness rather than recovery. Now, there are some muscarinic side effects that can occur if neostigmine was given alone. As the acetylcholine levels went up, as acetylcholinesterase was inhibited, that acetylcholine could cause bradycardia, hypersalivation, bronchoconstriction. Therefore, we add a drug like glycopyrrolate to block these muscarinic side effects. Organophosphate poisoning. Organophosphates are what's in some insecticides, can result in the sludge syndrome of salivation, lacrimation, urination, defecation, GI upset, and emesis, and it can add muscle weakness to that. And that is occurring because of this massive amount of acetylcholine that is around, and we can block that with atropine. There are some nerve toxins, botulism toxin and tetanus toxin. Botulism toxin and tetanus neurotoxin block the exocytosis of presynaptic vesicles. In the case of botulism, this results in muscle weakness or paralysis. There's acetylcholine presynaptically is not being released. In the case of tetanus, you're blocking inhibitory neurons, and if you block inhibitory neurons, you have the loss of inhibition, and you can get muscle spasms, tetanic muscle spasms. There are nerve gases, such as the G series, GA, GB, GD, that can be used in war, for example, and terror. And those are similar to the organophosphate insecticides in the fact that they inhibit acetylcholinesterase and raise acetylcholine levels dramatically, resulting in muscarinic activation. Muscarinic activation results in bradycardia, bronchoconstriction, meiosis, urination, emesis, increased bowel activity, and even muscle paralysis. And the treatment for this increased in acetylcholine activity is to block it with atropine. Pralidoxime used to be recommended to, quotes, reactivate acetylcholinesterase by removing the organophosphate compounds, but there's some new evidence that this may not be very effective. So atropine is the main treatment for nerve gas toxin. Neuromuscular blockade and pharmacodynamic responses. We talked about kinetic issues with renal failure, liver failure, and pseudocholinesterase. There are some pharmacodynamic responses, specifically potentiation of neuromuscular blockade, that we'll talk about next. The non-depolarizers and succinylcholine are both potentiated by anesthetics, specifically inhaled anesthetics, desflurane, sevoflurane, and isoflurane. TIVA, such as propofol, remifentanil, and nitrous oxide, do not potentiate the anesthetics like do des, sevo, and isoflurane. Patients on magnesium, such as in OB anesthesia, can have great prolongation and potentiation of non-depolarizers as well as succinylcholine neuromuscular blockade. There are some antibiotics that have prejunctional effects, probably is the pathophysiology, and these antibiotics that can potentiate neuromuscular blockade include aminoglycosides, tetracycline, clindamycin, bacitracin, but the classic drugs that we use for prophylaxis like cephalosporins do not, and the penicillins do not. Calcium channel blockers can potentiate neuromuscular blockade, and lithium, a treatment for mania, for example, can potentiate both non-depolarizers and depolarizers. Interestingly, if you use two different classes of neuromuscular blockers, one after the other and together, i.e. you put rocuronium into a patient and before they're fully recovered you give pancuronium, those drugs are in the same class. That is, drugs that neuromuscular blocking agents that end in onium are steroidal molecules. So pancuronium, vecuronium, rocuronium are steroid molecules. And if you add drugs in the same class, you will get an additive effect. But if you added drugs from a different class, for example, rocuronium and cisatracurium, rocuronium being a steroidal, cisatracurium being a benzoyl isoquinoline, two different classes of neuromuscular blocking agents, you can get a synergistic and somewhat unpredictable effect. Let's finish up talking about onset and recovery of neuromuscular blockade. The adductor pollicis at the wrist and the orbicularis oculi at the eye are typically monitored. The orbicularis oculi has the onset of blockade tends to be more rapid and correlates with what's going on with the laryngeal muscles. And recovery of the eye or orbicularis oculi occurs sooner than does the adductor pollicis or wrist. So if you want to know if a patient is fully recovered, you should go from the eye down to the wrist and monitor their adductor pollicis since it's the last to recover. And you will not monitor on the side that a patient has had a cerebral vascular accident, for example. If they had right-sided weakness and you monitored on that right side, they would have extrajunctional receptors there, and you would give larger doses than you need to get blockade if you were monitoring that side of the CVA. You would overdose the patient effectively. You should not monitor on the side of the CVA, but on the normal side. Recovery of neuromuscular blockade, we used to say a train of 4 of 0.7 ratio was adequate. Now since it's been shown that you can have impairment in swallowing and even laryngeal aspiration observed at train of 4 ratios as high as 0.9, we really want full reversal, a TOF 0.9 or above. Head lift, interestingly, does not guarantee a full train of 4 greater than 0.9. If you can hold a tongue depressor between your teeth, that's maybe a little bit higher, but even that, some books will say somewhere around about 0.85 is the train of 4 ratio when you're able to hold a tongue depressor between your teeth and not be able to have someone pull it out. Fade is what occurs when you cause a tetanic stimulus and hold it, and then as you're holding the stimulus, for example at the orbicularis oculi, that muscle relaxes. It cannot remain contracted. Fade occurs with non-depolarizing neuromuscular blocking agents. It can occur with succinylcholine if large doses of sux result in a phase 2 block, and it can occur with myasthenia gravis because as you stress the neuromuscular junction, it just can't keep up, and fade can occur. Double burst stimulation correlates closely with the TOF ratio, but it's just easier to detect fade manually. And fade can be detected up to a TOF range of approximately 0.5 to 0.6. Which of the following anesthetic agents would be expected to potentiate the effects of rocuronium neuromuscular blockade the most? Would it be sufentanil, propofol, nitrous oxide, or desflurane? And the answer is desflurane, the volatile anesthetic, potentiates it, while Teva-like anesthetics and nitrous oxide do not. This ends part 1 of a 3-part series on Keyword Review, Anesthetic Pharmacology 2016. Hope you have a great day.